panelists for their great inputs. So we'll quickly moving to our next session. It is a precision sequencing in hormone receptor positive metastatic breast cancer. So we will be discussing everything about it, endocrine agents, ADC, and what are the biomarkers. And to moderate this session, there's none other than Dr. T.P. Sahoo sir from Bhopal. So he will be moderating the session. And the panelists are Senior Dr. Vaibhav Chaudhary from Kokilaben Hospital, Mumbai, Dr. Bhavesh Poladia, dear senior from Thangam Cancer Center, Namakkal, Dr. Preeti Agarwal, our colleague from Narayana, Jaipur, Dr. Jyoti Bajpayee, our teacher and one of our mentors from Apollo Hospital, Navi Mumbai, Dr. Sunil Chopare, our colleague from Jaslok, Mumbai, Dr. Annaberson, so our dear junior from Actrek, Mumbai, Dr. Gaurav from our colleague from TMH Muzaffarpur, and Vipinesh, our colleague from TMH Varanasi. So over to Sahoo sir for this session.
Thank you, Amit. So I will share my slides. By the time, Amish boss, do you have a data on the US? What is the coverage of the scalp cooling?
What do you mean by coverage? I saw your.
Means
I
how many
couldn't understand.
centers, like how many of the centers really do cover and have it? Is it 100%? Because so it's better thing that in a affluent society, how much of these are really covered, and because we do not listen too much and do not hear a lot of data set from the from this segment actually.
So Paxman and EVA both put together, if I understand correctly, 87 centers in India right now have the machines, out of which around 16 to 17 have purchased in less than 6 months of time. And more people are asking me, calling me or messaging me कि Dr. Vora आपका experience कैसा था? So next year I understand that this should be more, Tarini.
Sure. Thank you, boss. I'll go move on as 30 minutes panel. So we will be only a request to the panelist. Just anyone from the organizer. I hope all the panelists are there. If there's someone missing, please let me know. So because I cannot see everyone. So that's one request. You can just unmute yourself and tell me that these two persons are not there. So I'll just move on. So 57 years old postmenopausal female, diagnosed with stage 4 metastatic breast cancer. So we have a ER of 7.7 by 8, PR strong positive, HER2 is only 1 plus. FISH was not done as we normally don't do for 1 plus. So basically it was HER2 low as per the today's criteria, but it was HER2 negative as we normally practice. The patient had lung mets with bone metastasis. The performance status was well maintained. It was treated with a ribociclib and letrozole. The PFS is of 15 months. And now after 15 months of PFS has 3 new liver deposits. So I'm pretty clear, and we are now reaching to really what has been given by Amit to us to discuss. So we have really covered the first line. So we will just go on. Quickly, Vaibhav, you are there?
Dr. Vaibhav and Dr. Vipinesh is not there, sir, right now. So
okay, just if they don't, if they come, just let me know. So yes, I'm cutting them off. Yeah. So Bhavesh, yes, quickly. As all CDK4/6 equal to you, quickly, yes, no. It's a very easy answer, Bhavesh.
They are different. Obviously, the side effect profiles are different. Although the features are same.
I am restricting it to efficacy. What do you feel they have a different efficacy pattern?
The efficacy pattern is almost similar. If we see the HR, if we see the data, HR is almost similar for all three. Okay. But toxicity profile matters a lot.
So we know that the ribociclib has an OS for data and which is there. The abemaciclib just missed the OS for this primary trial. The palbo is anyway, we all of us believe has missed the OS. But I feel the design of the trial, the patients were included were more to blame rather than the drug. And if you look at it, the PFS is dot on same what Bhavesh told, which is the primary efficacy. The OS is the data set where ribociclib actually scores over. So for all reasons, we can argue about it some other day, but we believe that they're pretty equal. But if someone is a very data-centric person, wants the OS to be the end criteria, level 1 is for ribo, PIMA probably for the endocrine resistant and probably is close second. My palbo is low down. So that's where it is. Okay. So,
Sir,
Preeti, Preeti,
Anberson here, sir.
Acha, you want to say, Anberson, tell me something. You want to say
Yes, sir.
something?
This is with respect to Italian real world study. In that real world study, they analyze different parameters. Those patients who are having endocrine resistant disease or PR negative or liver metastasis, those patients does better with abemaciclib compared to ribo and
I
palbociclib, sir.
agree.
So
So,
in
so I agree, but this we have to believe on the level, the randomized trial, and I do agree that the endocrine resistant refractory and somehow little bit of advantage to Abima, but all surrender for practical purpose, we can pick and choose, but this is what it is, and we may do the best for patient. So I'll move on to the real topic. So because
and
Anberson, you
next
were there.
point, sir. Next point I would like to add. There is a data with respect to Sonia study where they analyzed the role of ctDNA in patients with Sonia's same study subset of population. Those patients who had ctDNA positive, their response poor compared to those patients who are ctDNA negative. So probably in future we may have option of doing ctDNA upfront also, and those patients who are ctDNA negative, we can use those CDK4/6 inhibitor in second line also. That is one option, sir. It is recently
So
published, just a couple of weeks back.
Agreed. But the problem with ctDNA is we know it's a prognostic marker, but how predictive it is, when to change are the issues. So I'll leave it to some other day. So Dr. Preeti, are you there? Dr. Jyoti?
Yeah, hi, TP.
Hi, Jyoti. So one thing, for a new patient, I'm talking about the patient case which I told. For upfront patient metastatic breast cancer, do you run a full panel NGS now? Understandably, you are in a setting now where resource is no more a constraint for you. So do you run the NGS upfront for all? Or are you very clear that on the frontline setting, in a new case, metastatic de novo, you will be restricting to few only things?
So I think resources are always a gray area and graded. It is
Yeah.
never absolute wherever setting you and whichever setting you are. So I think we should be precisely deciding in the clinic about the
So what do you do?
precision
NGS
diagnostics
upfront?
and treatment. So I think in ideal situations, yes, we should be doing, and we get to know about the PIK3CA status, about ESR1 mutation, about MSI also, even TMB and NTRK in some cases may be used for future. But yes, it is. It is giving us information. So if money is not a constraint, we should be doing. Otherwise, we can reserve it for later lines also, or maybe we can use a focused panel also.
So basically, I get from Jyoti that yes, we should be using some form of molecular markers. If it is not a constraint, you'd be okay with the broad panel also, but you can also pick and choose. Anyone, Gaurav, you have a different answer, you feel the same? Gaurav? Anberson? Any different answer from Jyoti?
Sir, I'm not doing this NGS testing routinely, but
Okay.
in case some patients who are having bone only metastasis, in those patients, if I'm trying to look for PIK3CA mutation, I can go back to the same sample and then I can do NGS testing in the previous sample during the time of recurrence. Sir. That's what I'm doing.
Okay. So I feel because of short of time, two markers should be definitely done in the front line as per the data that's evolving. One is BRCA, that we should be having it. Second is we should be having the PIK3. And I will tell you in the recent what has been there, why PIK3 is important in the front line now. So I think these two data sets should be there because of the Inavo data set which has been published, which is a positive trial. I think PIK3 is something. So do you want to do NGS upfront? You may. Nothing is stopping us. But at least in on a table, we should have the ER, PR, HER2 new, and we should have the PIK3. But that would make a treatment decision now. And also we should be thinking of patients for BRCA. So that is what I think should be minimum of the two markers which should be done apart from the ERP HER2 new. Sunil, any different thoughts?
No, sir. I would do BRCA mutations and PIK3 mutations upfront. NGS as of now, not
Fine.
doing.
Fine. So no one is wrong here. So let's move to the case discussed. So we have a case of who has a progressive survival of 15 months. So this is the case which I just wanted people to get highlighted. Had been treated with CDK4/6 letrozole. PFS is for 15 months. Now has a progressive disease. So now we did a NGS, the BRCA was there was no mutation, the HRR was negative. ESR1 mutation was positive. PDL1 was 30%. So now, Bhavesh first. Bhavesh, do you think that you are very happy with this test report, or do you want anything more specific?
I think this is okay to shift to the next line.
Okay.
But
So my point here was, do you look into which type of ESR1 mutation and then you decide on treatment as of now?
not yet.
Okay. Jyoti or anyone or who does look at the type of ESR1 mutation and then tries to look at the treatment they want to do?
No.
Jyoti?
So I think
Currently, no, sir.
it's an evolving marker. I would say that we
Okay.
should be PIK3 while PIK3 generally when we do.
No, pick three apart. I'm just talking the ESR1 mutation.
Yeah, so in
Because
ESR,
there are, yeah.
ESR, we should be repeating ESR mutation. That's what I want, because it's an evolving thing and it keeps changing. I think that apart
So-
from that, I would not be interested to further, delineate.
So basically, ESR1 mutation, we look at the data set, especially from the UMBER study, which you have a very good publication. There are multiple type of ESR1 mutations. Really, we have not yet reached to a conclusion what ESR mutation, type ESR mutation is going to be, can it be predictive? But as of now, we should start looking at the type of mutation, start to learn those mutations. Some are very common, much more common than others. I'm not discussing that for this panel discussion. So I'll come down to a very important topic and very important trial. Amberson, how frequently should we test for ESR1 in the frontline metastatic when we are on CDK4/6 inhibitor with the AI?
Sir,
Do you
this is with
only
respect
do it?
to
Do you only do it at progression, or do you do it sequentially before that also?
since the drug is not available, sir, only during progression I'm doing. But as per
Okay.
Serena 6 trial, they saw the median time somewhere between 9 to 15 months. So majority of the patients, the ASR1 mutation, they're able to pick between 9 to 15 months. So that is
So
one point.
basically, you
And
have
other than
spoken
that,
of the
to take the sample of 300 patients, they screen total 3,000 patients. Sir.
agreed.
So whether the volume will be
100%, I'll come down to that. My point is, you have this Arena 6 with you. You spoke about it. I know I was coming to that only study. So are you convinced tomorrow, and are you convinced today at least, that I will practice Arena 6 and it is practice changing? Anbar sir,
sir,
do you
Serena
think
6
Serena
definitely
6 is
practice.
practice changing for you?
Data subset is good, sir. It is good. If the drug is available, I
It's
definitely
very
consider.
clear yes, no answer. Do you think it's practice
Yes, sir.
changing?
Yes, sir.
So
Yes,
it
sir.
is practice changing to you. Preeti, Serena 6, are you aware of the data set?
Yes, sir.
So do you think it's practice changing?
Yes, sir.
Okay. How many in this panel do not feel it's practice changing? So all of you feel it's practice changing?
Yes.
Okay. So that's good for me. So now let's switch off to Serena 6. I will just spend 5 minutes here and then go to the next part and 15 minutes, which is easier part. So this is important because tomorrow I know people will start doing this test. And mind you, Serena 6 wanted to do a serial ESR1 mutation on the ctDNA every 2 monthly or 3 monthly. Right, Anbasan? And then there was an arm which they wanted to change just on a mutation appearance, and the other arm they wanted to change on an anatomical progressive disease. And they found that there was a PFS advantage where the delta was around 7 months. Okay?
Yes.
So this is the data set. So they actually wanted to test the hypothesis, do the early ESR1 mutation if we pick up, will it turn into advantage of the PFS and OS? And thus, if you do it late, other co-mutations, if they appear, will they change the scenario? That is the basic concept how the Serena 6 wanted to. So point here is, I will ask you because all of you felt that it is practice changing, because I feel otherwise. I feel that I would still wait for a mature OS data. Because this was a trial which did not allow the camizestrant to be added to the patients on the control arm. There was nothing as a crossover in this trial. So mind you, we are changing something on ESR1 mutation, just appearance without radiological progression. And then the other arm we are doing on anatomical progression. So basically, do you feel that a 7 months unburdened PFS, which is clinically probably insignificant without a OS data set, would you feel it is good enough?
Sir, it will be difficult to get a OS data in breast cancer in the current scenario, sir. That is my first point.
Okay.
The other argument, why not to study this PFS2 also, there is some advantages there, sir. They've seen the PFS2 data also.
So now look at the PFS2 data. What is PFS2? If you look at it, PFS2 is a much more stronger surrogate marker for OS than PFS1. That's what it is coming down to. But the PFS2 for this experimental arm, for the pembrolizumab arm, will be actually the third line. Rather than, I hope you're getting the point, because they've already changed on CSR1 mutation. So on the on the experimental arm, the PFS2 will be different drug versus the PFS2 of the standard what we look at PFS2. So the PFS2 data is also insignificant. It is not a positive trial till now for even for PFS2. The PFS2, although the p-value is below 0.05, it is still not meeting its significance. Bhavesh, coming to you with what I've told, lack of crossover, imbalance in the post-progressive treatment there, and none of the patient in the control arm receiving the camizestrant with the lack of OS. And look at it, what my colleague spoke, that only 17% will develop a mutation ultimately. And of them, only 50% of those who developed a mutation were randomized. So basically, you are going to spend so much of money. And if you don't have OS advantage, do you think it is worthwhile to change practice now?
Not if we do not change any OS with this strategy, then probably this is not something which we should do it. But as of now, with PFS, if somebody asks, and if the nowadays patients will come and ask us, so in that case we have to offer. We cannot say that it is no advantage. We can say advantage there, but mature data is not there.
Okay.
I would like to add one point here, sir.
Yeah, Akhil, go. Okay.
Yes, sir. So, sir, PADA1 is published from 2022, but nobody
Exactly.
PADA1. Why?
Because we don't have camizestrant is a much costlier drug, na? PADA is a fulvestrant only.
Yes, sir. So, sir, what we were trying to do till now to utilize PADA1, we were trying to develop ddPCR for ESR1 at our own institute. We have done that. Now it is ready. But at the same time, when we got ddPCR ESR1, at the same time we have got camizestrant data, but camizestrant is presently not available and will be out of reach of pocket of our 95% of the patient. In the light of that, even if you have to utilize, we will be likely to follow PADA1 more than camizestrant.
My point is even with PADA1, my point is we have a pseudo progression. If it does not translate to OS advantage, are we not misutilizing the finances?
Yeah. So I agree with your point, sir. This is definitely.
It sounds something like screening, sir. If screening is not improving
No, so nothing.